Let's start with today's webinar then. So I welcome you all to my webinar. Today's topic is again rational management of Staphylococcus infection. So today we'll be discussing about MRSA. So again, I request all of you to kindly be on mute, and I'll be able to, I'll be happy to take the queries in the end. And if there are any queries, please post in the chat section. And there are a lot of polling questions, so I request you to respond to it when you get it. And all the materials, including the slide set and recording, will be shared. And again, please excuse for any inadvertent errors. And again, thank you all. So let's get started. So first, I have a question. A patient with osteomyelitis and in sepsis, what would be your empiric treatment? So we had discussed some part of the Staphylococcus aureus management previously. So yeah, I'll be starting the poll now. So Vancomycin plus Cloxycylin. So as I had discussed before, whenever you are starting empirically on any treatment, suspected, and in case of osteomyelitis, so obviously you'll be expecting Staphylococcus aureus, which is a predominant or the most common cause of osteomyelitis. So you'll have to cover Staphylococcus aureus, and empirically, whenever you're starting, you will have to give a coverage of glycopeptide with a beta-lactam. And this is one study. So again, I had forgot to put this in the previous one. So the empirical combination of vancomycin and beta-lactam for Staphylococcus bacteremia. This was so as we know, MSSA treatment, if you're giving vancomycin, it is associated with higher mortality. But if you are just starting the patient on vancomycin and then de-escalating, again, that was associated with inferior outcome. So if you do not add empiric MRSA coverage, so in countries like India where the MRSA rate is high, so there is high mortality. Hence, it is prudent that you add vancomycin. Now, if in case of MSSA, as we all know, vancomycin associated with higher mortality, up to 2 to 3 times higher. So you have to give this combination. So what if you follow the approach that initially you'll give vancomycin, once the culture report comes as MSSA, then you will stop the vancomycin. Again, this approach has been associated with higher mortality risk, around 4-fold mortality risk, and the time for de-escalation is around 3 days. Hence, it is recommended that you give adequate coverage of both MSSA and MRSA initially, that is beta-lactam and your vancomycin. So this was the next question. A 25-year-old male presented with OPD with severe sepsis. CRP was 200. Blood culture flagged positive, and it showed a growth of MSSA. Should the patient undergo TEE? Again, we had discussed this one. So you can put the Mrsa score, CRP more than 190, so score of 1, and blood culture positive, and severe sepsis score of 1 again. So it is a score of just 2. So you have to do TE if there is persistent bacteremia, and nowhere in any case of bacteremia, you shouldn't do the TE. Immediately because of high risk of false negativity. Hence, it is recommended you do TE at least 3 to 5 days after the episode of bacteremia. So next, I have one more question. So this total mixed response. Okay. Yes. So the patient is having MSSA from the pus, and the blood culture is sterile, and you have adequately drained it. So obviously, instead of the MSSA, the choice is between anti-staphylococcal penicillin and your cefazolin. So in this patient, you have adequately drained. So cefazolin is sufficient. And any abscesses, like you have to give sufficient anaerobic coverage. So metronidazole, and also they are not sure this metronidazole will also cover your amoebic liver abscess as well. So now coming on to the resistance in Staphylococcus aureus. So in 1940, when the penicillin was introduced, the same day, next day onwards, there was associated penicillin resistance Staphylococcus emerged. Then methicillin was introduced in around 1960s, and again by 1961 there was methicillin resistant Staph aureus which appeared. Then 1963 first hospital outbreak of MRSA, and late 90s again there was a community outbreak of MRSA, followed by your introduction of vancomycin and vancomycin intermediate Staphylococcus aureus, which was reported in Japan, and then 2002 is in USA, especially in the Western countries, there is higher incidence of your vancomycin resistant Staphylococcus aureus. So this is the resistance which is emerging, and in case of Staphylococcus aureus, and again, this is at cause. It is of a great concern. So next, again, I have one question. Most common type of resistance to beta-lactams in MRSA is, so I'm launching the poll now, the drug target. So if you look at the mechanism of MRSA, it is due to the alteration of target site. So this MEK gene will be responsible for synthesizing the PBP2 or 2' or 2A, which is associated with the reduced binding of the other beta-lactam drugs, and hence the resistance. So when we look at the MRSA prevalence in India, so this was a systematic literature review and meta-analysis. Here they have seen that prevalence of MRSA in India is around very high, around 27%, and higher proportion in men, more predominantly in men. And this will actually necessitate so that we take up necessary surveillance and preventive measures to ensure that this MRSA is contained. And this was the ICMR report of the antimicrobial resistance, the 2020, between Jan to December 2020. Overall proportion of MRSA was 41.4% in that, and the highest was in the north, around 54%, followed by east and west part of India. Southern zone had lower MRSA rate of around 33.4%. So why is this important? Knowing your local epidemiology is very important, so that based on your local epidemiology, you will be deciding whether to add an MRSA coverage to the patient or not. So next, I'm sure this is one of the common questions which you can expect. So let's end it here. So there is mixed response. So to detect the oxacillin resistant in all, which method detects all the answer is your oxacillin MIC. According to the CLSI, this is the only method which can detect oxacillin resistance in all Staphylococcus species. Your cefoxitin MIC, this diffusion is the most common method which is used. And again, this will miss in few species like Staphylococcus hemolyticus. So this table all of you will be very familiar with. So again, for detection of MRSA, you have both genotypic and phenotypic tests. Phenotypic test, the most commonly used is your cefoxitin disc diffusion method, or oxacillin screen agar. Oxacillin disc diffusion, again, because it requires certain condition, it is not used. And why is it called MRSA when you're detecting this? Again, one thing is methicillin drug which is not currently available. And that is why you can, cefoxitin or oxacillin is used as a surrogate marker. And for rapid detection of MRSA, you use this latex agglutination test, which will detect your PBP2A. And again, these are all phenotypic methods. To confirm that, you have to do the genotypic methods, which includes your PCR, which can be conventional, multiplex, or real-time PCR. So again, there are various types of MRSA. The most common one is hospital-acquired MRSA. Again, this is when you isolate MRSA in culture after 48 hours of hospital admission. Community-acquired or CA MRSA. LA MRSA is nothing but livestock-associated MRSA, which is seen in your animals. Again, HACO is nothing but healthcare-associated MRSA, when the initial culture was collected less than 48 hours. And after the hospital admission, and there was one risk factors, that is, it could be previous MRSA colonization, surgery, dialysis, etc. One important form of MRSA is inducible dormant MRSA. That is, here the if you do the PCR, MEK gene will be positive, but there will not be phenotypic expression of this MRSA. So the initial. So you will be detecting initially when you do the manual or phenotypic method, you will be isolating MSSA phenotype, and then it will get converted to the MRSA upon receiving the antibiotics. So now briefly on the anti-MRSA agents before I move on to the guidelines. So the most common one, whenever you think of MRSA, what comes to your mind is your vancomycin. It is a drug of choice for all the Staphylococcus infections. And again, it's a glycopeptide antibiotic, which depends, PKPD parameter is your AUC by MIC, and it's a bactericidal agent. And as we have discussed, it kills MSA slower and incomplete in case of MSSA. It has a very good tissue penetration. That's why it is preferred in most types of your Staphylococcus infection, but the penetration is comparatively lesser in case of lung and bone. And the adverse effects, as we all know, the most widely known adverse effect is the red man syndrome or the anaphylaxis. Soon after the infusion of vancomycin, the patients will develop angioedema-like features. And then the most common adverse effects is your nephrotoxicity and ototoxicity. Again, it is not as such because vancomycin is very nephrotoxic because of the concomitant use of the nephrotoxic drugs. So that is why. And again, it requires a renal dose adjustment based on the renal clearance of the patient. Teicoplanin is like a brother of your vancomycin. Both are known to be therapeutically equally effective. But the side effect profile is comparatively better in case of teicoplanin, and Redman syndrome is very rare. So even if there is a patient is having Redman syndrome or the adverse effect with the vancomycin, you can still consider giving teicoplanin, and it has a lesser propensity to cause nephrotoxic than the vancomycin. And 90% is plasma bound, and it has a T-half is very long, around 160 hours. So you can give an OD dose, which is sufficient. And again, it requires renal adjustment. When you do the renal adjustment, the dose will come like you will be giving the teicoplanin once in 2 days or once in 3 days. So this is briefly about your teicoplanin. Next is your linezolid. It's a very good anti-MRSA drug, but the major concern is because it is a bacteriostatic agent. And as we all know, it is a protein synthesis inhibitor at 50S ribosome. And one important property of the linezolid is your antitoxin effect. Because it's a protein synthesis inhibitor, it will have antitoxin effects. That is, it will inhibit your PVL toxin, hemolysis, and toxic shock syndrome toxin. So wherever you require antitoxin effects, so in that situation, you can add linezolid. And it achieves very high level in the epithelial lining of the lungs, and hence it is a preferred drug in case of pneumonia. Teicoplanin has very good penetration into your bones, hence it is preferred in case of your osteomyelitis or bone and joint infection. But it has a very low penetration into the CNS, hence it is not preferred in case of your CNS infection. So again, when we look at teicoplanin versus vancomycin, so this was a Cochrane review where they have done the systematic review and meta-analysis, where they have found that all of the parameters like clinical cure, microbiological cure was equivalent in between teicoplanin and vancomycin. The nephrotoxic potential was reduced by 34% in the patients with vancomycin. Hence, in any patients who you're thinking the patient may have or may undergo AKI, so in that situation you can prefer teicoplanin over vancomycin. Then linezolid. So let's just compare these drugs. So I compared vancomycin with teicoplanin. Next, let's look into vancomycin versus linezolid, especially in case of skin and soft tissue infection. Linezolid is preferred drug. So this is a so this was a study which was published, so where they showed that linezolid outcomes were much superior compared to vancomycin, and though the adverse effect profile remained the same, but the efficacy wise, the microbiological cure was much faster in case of linezolid, and that is why in skin and soft tissue infection, linezolid is preferred over vancomycin. And also one more added effect is your antitoxin effect. So in patients having suspected to have PVL toxin mediated necrotizing fasciitis or toxic shock syndrome associated with necrotizing fasciitis, this linezolid will have a better and good outcome compared to your vancomycin. This was another meta-analysis which also showed the same thing. Linezolid was associated with significantly better clinical and microbiological cure when compared to vancomycin in cases of your skin and soft tissue infection. Next, linezolid in pneumonia. So again, this is one of the debated topics. So this was a meta-analysis where they compared vancomycin and linezolid in pneumonia. And what they found was clinical and microbiological eradication rate was much better in linezolid when compared to your vancomycin. So again, linezolid can be preferred in case of your over vancomycin in cases of your pneumonia. So this was again, they have in this alternatives to vancomycin for treatment of MSSA infections, MRSA infections. So here they have evaluated linezolid for bacteremia as well. It was found to be non-inferior to vancomycin. So again, it is non-inferior, but the major concern is because your linezolid is a bacteriostatic agent, and in general, the principle of treatment is in cases of bacteremia and endocarditis, you will have to treat with a bactericidal agent so that the response is good. So next important anti-MRSA drug is your Adaptomycin. It's a lipopeptide class antibiotic which disrupts the cell membrane function via calcium-dependent binding. It is again a bactericidal agent and it is concentrated dependent kinetics. And it is effective against your MRSA, Visa, and your VRSA. And it is FDA approved for your Staphylococcus aureus bacteremia as well as right-sided endocarditis. And the usual dosage is 6 mg per kg per day. And this, I am sure all of you will be familiar with, one of the important MCQs. So it has no action in pneumonia. Why? Because the pulmonary surfactants will inactivate the drug. And the toxicity is muscle toxicity. So you have to follow up with the serum creatinine kinase monitoring. And most of the studies have showed that it is non-inferior to vancomycin in cases of treatment of MRSA bacteremia. So where will you prefer? So it is actually non-inferior, and you can prefer, you can treat with Adaptomycin. The major drawback is its cost. Next is usually when we use Adaptomycin is whenever the patient is having when vancomycin you have started, the patient has not responded, then persistent bacteremia is there, then the patient, usually that is a scenario where the patient will be shifted on Adaptomycin. So the indications of use is when there is severe sepsis, vancomycin has been used in previous 30 days, and there is high local prevalence of vancomycin MIC more than 1.5. And obviously, so in the case of renal impairment, your Adaptomycin is a preferred agent if you can't even give teicoplanin. Again, the cause of concern is the increasing incidence of Adaptomycin non-susceptible isolates. So this was one meta-analysis where they compared your Adaptomycin with vancomycin for bloodstream infection with or without endocarditis, and there was no difference between it was associated with again there was no, it was a non-inferiority study. Then this was one study where they have compared the effectiveness of shifting Adaptomycin versus remaining on vancomycin among the patients with MRSA. So basically, they've analyzed what is the effect of initially giving vancomycin, then shifting to Adaptomycin or remaining on only on vancomycin. Here, they have seen that if the patient will be shifted to Adaptomycin within 3 days after diagnosis, it was associated with lower 30-day mortality. Whereas if it is shifted later, after 3 days, there was no difference in the outcome. So if you have to make the switch between vancomycin to Adaptomycin, it is ideally between first day to the, once the culture has come positive as grown MRSA, within 3 days of vancomycin, it is better if you want to shift to Adaptomycin. Beyond that, there was no associated with any added benefit. So a brief about the newer MRSA drugs which are there. So the first one is your ceftaroline. Ceftaroline, again, as we know, it is one of the, it is the fifth generation cephalosporin, which remains effective, which is only beta-lactams, which will remain effective in cases of MRSA. Why is it effective, though it is a beta-lactam? Because there are some structural alterations which have been done, which will enhance the binding. So instead of binding to the normal PBP, this will go and bind to altered PBP2A, as well as it has enhanced beta-lactamase. It is not subjected to the beta-lactamase inactivation. So this will remain effective against your MSSA, MRSA, VISA, VRSA, and as well as Enterococcus fecalis. Again, being a beta-lactam drug, it is a bactericidal agent and has a long post-antibiotic effect, and it can be given only parent drug. So this is also one of the major drawbacks. So in cases you can't use whenever the patient has to be given long duration of antibiotic, it's better if a drug has IV and oral options, so that you can later shift the patient on oral. And mostly it is combined. Ceftaroline, it is mostly used as combination, and in combination with daptomycin, it is associated with increased binding. So it will enhance the binding of daptomycin and hence enhanced killing. So it is used in combination with your daptomycin, and FDA it has been approved for SST, skin and soft tissue infection, and community acquired pneumonia. Again, there is a capture trial which has proven that it in bone and joint infection, again the cure rate was around 92%. Next, our levonadifloxacin. This is one of the indigenous drugs. So this was developed in India. So again, this is one of the cephalosporin, and usually the cephalosporin will target your topoisomerase. So this one preferentially targets your DNA gyrase, and hence it remains active. And it is active against your MRSA, VISA, VRSA, etc. And again, it is bactericidal, and even it will remain bactericidal even when there is high inoculum, as well as acidic environment. So why is this acidic environment? So acidic environment, even in your abscesses and all, there will be acidic environment. So this will remain active in that situation. And one important thing, it has both IV or parenteral and oral formulation, and even the oral formulation has a good bioavailability of up to 90%. And it will even permeate the biofilm. And currently they have shown that there are no adverse effects like QT prolongation or nephrotoxicity. And currently it has been DCGI approved for ABSSSI. What is ABSSSI? So it is nothing but acute bacterial skin and skin structure infection. So this is a new term which has been coined by FDA for denoting skin and soft tissue infections which are more than 75 meters square. And again, this is the phase 3 trial, it was seen that it was non-inferior to linezolid in treatment of your skin and soft tissue infection. And then we have the newer glycopeptides like elavancin, dalbavancin, and orteravancin. They are basically semi-synthetic glycopeptide derivatives, and they will have additional lipophilic side chain which will confer this enhanced potency, and it remains active against your MRSA, VISA, and even DAPTO resistant isolates. And currently it has been approved by FDA for your skin and skin structure infection, HAP, and your VAP, that is ventilator associated pneumonia. Again, the most lucrative things about these newer drugs is the dosing. So telavancin, OD dose is sufficient. Dalbavancin, it has such a high T-half that it can be given weekly once as well, similarly your orteravancin. Again, the RCTs are ongoing for treatment of other infections like osteomyelitis, and they do not require TDM. And the adverse effect, being a glycopeptide, nephrotoxicity remains as one of the adverse effect. Kedazolid, again, it is like your linezolid, but with an additional hydroxymethyl groups. Hence, it remains active even in isolates which are linezolid resistant. Again, both IV and oral formulations are available, and it is found to be non-inferior to linezolid. And again, one important property is the typical myelotoxicity of linezolid is much lesser in cases of this alternative. So that brings us to this. So today I'll be discussing mainly the IDSA guidelines for treatment of your MRSA in adults and children, as well as like I'll be comparing these guidelines. So there is one newer guideline for MRSA, which has this published in JAG, antimicrobial resistance for UK, as well as we have our Indian consensus statement, I can say, treatment of MRSA infection in India. And again, this was given by a committee which contained your ID experts, your clinical microbiologists, the critical care experts. So yeah, so we'll be discussing this with special emphasis on your Indian review. So general, so the treatment of MRSA, as I have mentioned multiple times, it is first and foremost should always be prompt source control. If you're not having adequate source control, how much ever you pump in the antibiotics, it's not going to act. And then prompt initiation of the appropriate antimicrobial. So you have to differentiate whether it's MRSA, MSSA, and you have to give an appropriate antimicrobial. And in all that situation, it will be mostly vancomycin or teicoplanin, which is the drug of choice for MRSA. And teicoplanin can be used in all the situations where you can use vancomycin, especially where nephrotoxicity is the major concern. And other alternatives which can be used include your Adaptomycin and other drugs like telavancin, ceftaroline, and linezolid may be alternative. Again, we will be discussing as we go on through the guidelines and through the situations, various in types of infection, where you will prefer one over the other. So again, now I have one polling question. So it's a very common practice. Whenever there is an abscess and whenever you do IND, you have to give an antibiotic, but it is not so. So in this case, the patient is having just a single abscess and no systematic complaints, and his hemodynamically stable. So just IND alone will be sufficient. So with that, let's start with the skin and soft tissue infections. So for simple abscesses or boils, it should be managed only by incision and drainage. And when do you recommend, or when do you add an antibiotic? If there are multiple abscesses, or it is a severe and extensive disease, and that abscess is rapidly progressing to cellulitis, or when the patient is having signs and symptoms of systematic illness, or if the patient is immunocompromised or having any other comorbidities, and if in extreme of age groups, and abscesses which are in difficult to treat areas like your genitalia, etc. And if there is lack of response, so initially you just do IND, but then the abscess recurs. So in this situation only, you need to add an antibiotic, otherwise there is no indication. So let's start with this. First I'll be discussing the Indian guideline or consensus, not guideline, Indian consensus. And afterwards I'll be comparing the same thing with your IDSA as well as the UK guidelines. So again, in India, as we have seen, the proportion of staphylococcal SSTI due to MRSA may range from between 7 to 70%. And when you will give MRSA cover, only in patients who are critically ill. And IND is the recommended treatment of choice, only IND, no antibiotic, for simple abscesses and furuncle. And in case you have to, if the patient is having complicated SSTI, as I mentioned, so in that situation, the drug of choice for empiric therapy will always remain your vancomycin and teicoplanin. You can use Adaptomycin, ceftaroline if they are as alternative agents. And once you get the report, the sensitivity, you drain an abscess and send, and the culture report remains, the isolate remains susceptible, you can shift to the other lower drugs like clindamycin or cotrimoxazole. And the duration, so for any uncomplicated SSTI, for it is around 1 week, and in cases of your complicated SSTI, it is 2 to 3 weeks. So this is the. So when we compare the same thing with IDSA, so IDSA have separated, they have properly divided into various situations. So when there is patient is having just impetigo, so you can just give topical mupirocin or fusidic acid. Again, abscesses, they recommend the same. In case of uncomplicated, you just do IND. In case of complicated, you will be adding the agents. Again, Then if the patient, next situation is patients having purulent cellulitis. So whenever patient is having purulent cellulitis, it is mostly the most common organism you will be suspecting is the Staphylococcus aureus. So you have to add an MRSA cover. So you can use either clindamycin or 4-trimoxazole or doxycycline or linezolid. In cases of a non-purulent cellulitis, so if there is no pus production or the pus formation is not there, then you will be suspecting more of beta hemolytic streptococci induced infection. So in that case, again, your clinda, 4-trimoxazole, linezolid will cover both your staphylococcus as well as streptococci. That is why most commonly these are the agents you will see in any surgery ward being used. And the duration of treatment is 5 to 10 days. When we look at the UK guideline, it is more or less same. So in cases of abscesses, because in the situation of PVL toxin expression is higher, and so they do the PFG typing, and if there is PFG USA 300 strain, which is notorious for PVL production, in that case you should be adding clindamycin or 4-trimoxazole as an antitoxin agent. And the appropriate management of SSTI, first and foremost, is your surgical debridement, followed by empirically broad spectrum antibiotic. In case of severe SSTI, you will be giving vancomycin is the first choice, followed by linezolid, adaptomycin. In cases of mild SSTI, you can just give clindamycin, 4-trimoxazole or doxycycline. And these are the dosages of the various drugs. So in case of purulent cellulitis, 4-trimoxazole doxy. In case of non-purulent, you can, if it is an MSSA strain, then you can obviously give sulflexin or dicloxycillin. If it's an MRSA, clinda or linezolid. Complicated SSTI, vancomycin, linezolid, adaptomycin. So if when you compare, so in case of Indian, you can just see they have mentioned only vancomycin as a cover for all the type of SSTI. Here we have proper division based on the degree of type of skin and soft tissue infection. So next, I thought I will add this one on topic on recurrent MRSA and skin and soft tissue infection, like one of the question which was asked last time. So the first and foremost, what we have to emphasize on is, apart from if it is in the infant age group or the child age group, so then you'll have to screen for your primary immunodeficiency. If in an adult age group, first and foremost, first emphasis will be on personal hygiene and the wound care. So you should make sure that the draining wounds are adequately covered, hand hygiene is done, and personal or the sharing of the belongings should be avoided. Then we will look into the decolonization therapy if the patient is not responding to your personal hygiene and wound care. So decolonization only if the patient is still having, despite this, and that you can include your nasal decolonization with mupirocin twice daily for 5 to 10 days. Or if at all there is no response to that, you can even give topical body decolonization with chlorhexidine bath for 5 to 14 days. And oral antibiotics are not routinely recommended in cases of this. And if there is still recurrence, even after adequate proper personal hygiene and wound care and decolonization, and there is no other underlying primary immunodeficiency, you can give an oral antimicrobial with or without rifampicin. And routinely, there is no requirement. So once you decolonize the patient, there is no recommendation for culturing after the decolonization, if there is no active lesion which is present. So next situation, we have the urinary tract infection. So first and foremost, whenever the patient is having any urinary tract infection, you have to rule out. If the patient is having some systematic symptoms, you will also have to rule out the concurrent MRSA bacteremia. And so if the patient is just having cystitis or lower UTI, you can just give oral antibiotics like doxycycline, trimethoprim, ciprofloxacin, or nitrofurantoin. 4-trimoxazole. Nitrofurantoin is better avoided. Then, in cases of complicated UTI, you can give IV glycopeptides like vancomycin or teicoplanin. If they are contraindicated for any other reason, you can give Adaptomycin. In cases of catheter-associated UTI, first and foremost, you need to replace the catheter, repeat the culture so as to rule out the colonization. Then, if the patient is still having growth, then you can still give a single dose of gentamicin. Alternatively, you can even give single dose of vancomycin or teicoplanin. Linezolid is not recommended because it is very poor renal excretion and hence will not have any action. So here next, I have a question. We launch this poll of community acquired pneumonia. 4 days history only is there, and currently she has just been hospitalized and intubated. So you have to give adequate cover of your typical community acquired organism. So you have to give a beta-lactam with a macrolide, that is the treatment regimen. MRSA cover in this patient is not indicated as of now because she has no other comorbidities associated with your MRSA. So for that, let's look into the guidelines. So in this situation, the ceftriaxone and azithromycin is sufficient. So again, evidence regarding prevalence of MRSA is limited. MRSA is a very infrequent cause of community acquired pneumonia in India. Of all the staphylococci associated community acquired pneumonia, only around 30 to 60% are MRSA. And so in which patients will you give this MRSA cover? So old age, when the patient's age is more than 60 years, having chronic respiratory disease, then history of hospitalization for more than 48 hours, or previous history of hospitalization for more than 3 months, chronic dialysis within 1 month, or a family member with an MDR positive organism, or if the patient is on immunosuppression, then you will just think of adding an MRSA cover, not in all the situations. And again, and few situations where you will be having, you have to add an MRSA cover as soon as you diagnose this, if there is any cavitation or necrotizing pneumonia features, along with necrotizing pneumonia features, or hemoptysis with pleural effusion with necrotizing pneumonia, patients having neutropenia, or concomitant SSTI. So when you're suspecting concomitant, there is, along with skin and soft tissue infection, there is also pneumonia, then you will have to give the MRSA coverage. So this is the risk factors. If any of these risk factors are present, so post-influenza Staphylococcus aureus pneumonia is very common. So if the patient is having influenza and then he's developing a pneumonia, then you can add an MRSA coverage. And apart from that, IV drug abuses, recent antibiotic, nasal colonization of MRSA, and so all the critically ill patients, you will just evaluate for the presence of risk factor, and if it is positive, then you will be adding the MRSA cover. So what is the treatment of choice? As I mentioned before also, teicoplanin has a better good tissue penetration, or the ELF concentration in the lungs. So teicoplanin is preferred over vancomycin in MRSA pneumonia. And one more, I have showed that in pneumonia, linezolid is better penetration, better drug compared to your vancomycin according to few studies. So while in Indian situation, linezolid is better avoided, though it has much better response, because one thing, we are because of potential masking of the tuberculosis. And if the patient is having any necrotizing pneumonia features, then wherever you require antitoxin cover, you can add clindamycin along with vanco or teico. And the duration for community acquired pneumonia is 14 to 21 days. So next, just a brief one, ventilator associated pneumonia. Again, most common cause is your gram negative. So it is not necessary that all the patients with VAP you will cover MRSA. So in India, mostly it is less than 20%. So if it is more than 25%, then you can add the cover of MRSA for in patients with VAP. And again, and re-emphasizing the fact, though linezolid has better efficacy, it is preferably avoided in Indian setting. Again, one thing is, in case of community acquired pneumonia, you'll be if the patient is treated and then you are looking for gene expert, the sensitivity of gene expert will fall. In case of ventilator associated pneumonia, again, it's a crucial drug for MDR TB. So one of the in case of BPAL regimen, which is a shorter course for anti-tuberculosis, if there is exposure to linezolid for more than 1 month, you can't give that regimen. So it is better to be avoided in Indian situation. So where you will give MRSA cover in cases of patients with VAP. So emergency intubation, tracheostomy, re-intubation, elderly patients, male patients, and on hospitalized or on mechanical ventilation for more than 5 days. So in that situation, you can think of adding the MRSA cover. So again, when we compare the IDSA with this Indian part, so empiric treatment, they have mentioned very specific. So whenever the patient is having ICU admission, necrotizing or cavitatory infiltrates and empyema, in cases of severe community acquired pneumonia, in IDSA, according to IDSA, you can give the MRSA cover, because as you know, the Western countries have much higher prevalence of MRSA. And in cases of hospital acquired MRSA, the treatment of choice again, vancomycin or linezolid or clindamycin whenever antitoxin effect is desired. And that again, the treatment, the duration is 7 to 21 days. And the UK guidelines, they give separate for different types of pneumonia. For necrotizing pneumonia, as we all know, you have to give an antitoxin agent. So you can give along with vanco or linezolid, clindamycin or rifampicin can be added. In case of nosocomial pneumonia, again, vancomycin or linezolid is the treatment of choice. And again, no adaptomycin in cases of pneumonia. Next, coming to the bloodstream infection. So this I think we have already discussed in the last one. So I hope all of you will be able to answer this. Duration, I didn't expect the mixed response here. So duration of treatment for complicated is 4 weeks and uncomplicated is 2 weeks after the culture is sterile. So here in this case, the answer is C. Complicated bacteremia, you have to give for 4 weeks, and uncomplicated bacteremia for 2 weeks after the culture is sterile. So first, let's discuss about catheter-related bloodstream infection. Again, in Indian scenario, CRBSA is higher compared to the Western countries. And again, most common cause of this CRBSA is predominantly a gram-negative pathogens, and gram-positive is relatively lesser. And in the gram-positive, Staphylococcus aureus is the more common gram-positive, and amongst them, 35 to 80% are methicillin resistant. So when will you give empiric cover for MRSA? When there is an issue with sterility is compromised during the insertion, or the patient is already an MRSA colonizer, or patients having history of MRSA infection, and usually in cases of dialysis patients and IV drug abusers. So in that situation, you can add this empiric MRSA cover. And if the local prevalence of MRSA is less than 10%, there is no requirement of your MRSA cover. And to detect, so when will you tell the patient is having CRBSI? So for that, you have to send one peripheral and one, at least one peripheral and one central, that is a paired blood culture should be sent, and within 10 minutes of each other. And when the central is flagging before 2 hours before the peripheral, then you will be telling it to be catheter-associated bloodstream infection. It is based on the differential time to positivity. Again, the drug of choice is vancomycin or teicoplanin. And in patients who are critically sick, you have to give the vancomycin loading dose. Alternatively, linezolid or adaptomycin can be used, and teicoplanin whenever you are suspecting renal function is impaired. So, and first and foremost, as I mentioned, always you have to do the adequate source control. So that is why you have to remove the central line, and blood culture should be repeated every 48 to 72 hours until it is negative. So complicated bacteremia. So when will you be telling the patient is having complicated bacteremia? It is defined as patients having positive blood cultures along with either features of endocarditis, or the patients having implanted prosthesis, or patients having persistent bacteremia or persistent fever even after 72 hours after initiating the effective antibacterial therapy. And there is some evidence, so you have evidence of metastatic site infection. So if the patient is having any of these following features, you will be calling or labeling it as complicated bacteremia. And for complicated bacteremia, the duration of treatment should be 4 to 6 weeks. And if the patient is not having any of these features, and he is afebrile and his subsequent cultures are negative, and there are no metastatic sites of infection or endocarditis, it is labeled as uncomplicated bacteremia, and you can give just 2 weeks of therapy. And very important to note that the entire duration of this therapy should be IV or parenteral, and there should not be oral switch. And as I mentioned, you will always have to rule out the infective endocarditis by doing your TE. So around 40% of the staph infection is associated with infective endocarditis or MRSA. And when again, based on the history risk factors for MRSA, you will add the MRS empiric coverage. And the treatment of anti-MRSA therapy, that is vancomycin or the adaptomycin, is the preferred treatment for infective endocarditis. And in case you're using adaptomycin, it is preferred that you give a higher dose, that is usual dose is 6 mg per kg. Higher dose 8 to 10 mg per kg can be given, because few studies have showed that adaptomycin at a higher dose, especially in patients having endocarditis, will have a better response. And addition of gentamicin and rifampicin rifampicin can be done in patients having prosthetic valve endocarditis and not in native valve endocarditis. So if you're giving gentamicin, you can give for 2 weeks, and if you're giving rifampicin for 6 weeks, important to know that rifampicin you will be adding at least after 3 to 4 days after you start the vancomycin. And optimal duration for endocarditis is 6 weeks after you obtain a negative culture. And the entire duration of treatment should be IV. And when you compare the same now with IDSA and UK, mostly the treatment of choice, mostly everything remains the same. IDSA gives a common guideline for bacteremia and native endocarditis. And the same thing, you have to identify the source of infection, remove the source, repeat blood culture every 2 to 4 days. And same duration for uncomplicated 2 weeks, and complicated they tell 4 to 6 weeks. And in case of UK, bacteremia guidelines are published along with this anti-MRSA. For endocarditis guidelines, they have separate BSAC guidelines. And the same way for endocarditis. So both of them recommend the similar things. So when we look at BSAC, so for MRSA, vancomycin. For native valve endocarditis, there's vancomycin. Here I have for 4 weeks. And this is according to BSAC, where they add rifampicin. In prosthetic valve endocarditis, vancomycin, rifampicin with gentamicin is the drug of choice. But in case of IDSA or AHA, the guidelines for endocarditis, they recommend only vancomycin or adaptomycin for 6 weeks. Whereas in case of prosthetic valve, only in prosthetic valve endocarditis, you need to add rifampicin and gentamicin. And the duration of treatment is up more than 6 weeks. Next, coming to the bone and joint infection. So first we'll discuss about the acute septic arthritis. In India, the septic arthritis prevalence of MRSA is 20 to 40%. Septic arthritis, again, the most common causes of Staphylococcus aureus. And again, Vanco or Tico should be the treatment, empiric treatment. And the duration, optimal duration is 3 to 4 weeks after you adequately drain. And in situations where you will add empiric coverage for MRSA is if the patient is having history of recent hospitalization, trauma, And previous, when he was admitted, there was MRSA infection or colonization, IV drug abuses, etc. So that was septic arthritis. And osteomyelitis. So again, Staphylococcus osteomyelitis is the most common one, around 1/3. So empiric MRSA covered for acute osteomyelitis if the patient is having high fever and is rapidly progressing, wherever the local prevalence of MRSA is high and multifocal infection. Vancomycin or teicoplanin is the drug of choice for MRSA osteomyelitis. Again, as I mentioned, teicoplanin has higher bone levels and lower toxicity. And again, as I mentioned, teicoplanin you can give as a OD dose. So possibility to convert to OPAT regimen, that is at the later stage. Hence, it is preferred over the vancomycin in cases of your osteomyelitis. And you have to use a higher dose. And so initial 2 weeks. So in case of septic arthritis or osteomyelitis, the 2 weeks initially you can give parenteral. Later you can shift to the oral. So the oral switch over when you do, it will be based on the susceptibility report. So you can give rifampicin should never be given as a single agent. It should always be combined with the fluoroquinolone. So levo plus rifampicin can be given, or you can give monotherapy with linezolid or cotrimoxazole or clindamycin. The duration of MRSA osteomyelitis is 6 to 8 weeks. And usually it is longer in MRSA when compared to your MSSA. Again, the first and for when we compare the other guidelines with IDSA, same thing. Adequate surgical debridement and drainage of the abscess is the first and foremost step. Then initial 2 weeks IV vanco followed by oral conversion. Even they do not recommend rifampicin monotherapy, and rifampicin should be added only after the clearance of the bacteremia. For acute osteomyelitis, so I say they have differentiated osteomyelitis acute and chronic. Acute osteomyelitis, the duration of treatment is for up to 8 weeks, initial 2 weeks IV followed by 4 to 6 weeks of oral. Chronic osteomyelitis, the treatment is more prolonged, and the treatment response can be assessed by the fall in ESR or CRP. Septic arthritis, again, after drainage, 3 to 4 weeks of treatment. Then device associated with the prosthetic joint infections, 3 to 6 months treatment is required. For UK, in the UK, it is the same, mostly it is the same. Again, the vancomycin or teicoplanin. They have not mentioned, they do not give preference of teicoplanin over vancomycin in any of these guidelines. Majorly because teicoplanin is mostly not available there. And as I mentioned, rifampicin or quinolone can only be used in combination, but not as a single therapy. Next, prosthetic joint infection. Again, most of these are mostly due to the gram-negative bacilli. MRSA is comparatively rare, so you will not add empiric MRSA cover. And you will be adding only in cases of life-threatening situation. And vancomycin or teico is a drug of choice. Alternatively, adaptomycin or linezolid can be used. So if the prosthesis is removed, then you can give up to 6 weeks therapy. And if the prosthesis is retained, then you have to give initial 6 weeks followed by 3 to 6 months of oral therapy. That is, the suppressive bacterial therapy should be continued. And again, rifampicin is one of the very good drug which has anti-biofilm effects. So that is why you will adding that and along with one more anti-staphylococcal agent and never as single therapy. So this is the IDSA guideline for PJI. I will not be going to detail. Again, this PJI is one more topic in individual topic of discussion as such. So for early onset PJI, it's recommended for 3 months. For hip and 6 months for knee, and in cases of late onset, you mostly have to do the device removal. If it is not, then you have to give long-term oral suppressive antibiotics. Next, talking about MRSA meningitis. Again, nosocomial, whenever patient is having nosocomial meningitis, then you can suspect gram-negative and MRSA. Otherwise, they are not the typical agents of your meningitis. And you have to add an MRSA cover in all cases of nosocomial meningitis, that is especially your shunt infections. So again, vancomycin is a drug of choice, and optimum duration of treatment is 2 to 3 weeks. And if the patient has ventriculitis, it should be ideally administered in the intrathecal and intraventricular route. So when we compare the IDSA, so IDSA again, IV vancomycin, so the drug of choice for meningitis for 2 weeks. And sometimes some experts suggest addition of rifampin as well. Alternatively, linezolid or cotrimoxazole also can be used. That is what is mentioned in IDSA. In case of shunt-associated infection, the shunt removal should be is recommended, and the shunt should not be replaced until the CSF cultures are negative. But UK guideline, again, IV vancomycin is the drug of choice. But here they mention clearly, do not use clindamycin, chloramphenicol, or linezolid because they are not bactericidal. So this is one of the difference when I found in the UK guideline. Then when we talk about brain abscesses, here brain abscesses, the drug of choice is ceftriaxone plus metronidazole should be the empiric choice for brain abscess. And in case of hospital acquired brain abscess, then you will be adding the MRSA cover. And in that situation, vancomycin will become your drug of choice. And again, based on the patient's response, you have to do follow-up imaging. The usual duration is around 4 to 8 weeks based on the patient's response. CSF shunt associated infection. Again, vancomycin, you will be adding empiric cover only if it is the prevalence is high, and vancomycin is a drug of choice. If it is refractory to vanco, linezolid can be used. 2 to 3 weeks is the optimum duration of therapy. So in cases of brain abscesses, again, the first and foremost in IDSA, the drainage of the abscess is very, very important. For vancomycin, afterwards you will give the vancomycin for 4 to 6 weeks. Addition of rifampin also is used, suggested by some of the experts. And UK, again, I have already mentioned, they do not recommend use of clindamycin, chloramphenicol, or linezolid. So that was the treatment. So again, one important factor in your whenever you're treating the patient with vancomycin or teicoplanin is, it is recommended that you have to do therapeutic drug monitoring. So you may be thinking of giving or treating adequately, but the patients may not have adequate levels of the drug. So ideally, it is recommended in all the patients who are on vancomycin or teico should undergo therapeutic drug monitoring, but and especially in patients who are critically sick and having associated renal dysfunction, serious infection, or you have to give prolonged therapy, it is highly recommended you should do the vancomycin level monitoring. And if you go to this ideal situation, you have to do therapeutic every day, but in Indian scenario, it is next to impossible. At least weekly monitoring should be done. And again, what you have to do, AUC by MIC ratio is a better indicator than trough level, and desirable AUC by MIC ratio is 400 to 600. And teicoplanin, you measure the serum trough level. Why AUC by MIC for vancomycin not trough level is because when you look at the trough level, there was higher risk of nephrotoxicity. Hence, for vancomycin, it is recommended you do the AUC by MIC, whereas in case of teicoplanin, it's the trough level, and you have to maintain the teicoplanin trough level more than 20. So next, here I have a case, a 40-year-old male with high-grade tibia osteosarcoma on chemotherapy, having an IV port in C2, presented with abrupt onset of high-grade fever, restricted movements along with the swelling and tenderness of the left knee joint. TLC was raised 18,000, which was 85% neutrophilic. Blood culture and knee joint aspirate has been sent for culture, and he was started on empirically on meropenem. First question, I couldn't link with the poll, so you can just unmute yourself. Anyone who wants to answer, was the empiric and treatment correct? So obviously no. The patient is having history of osteosarcoma with IV port in CO2. So mostly you have to also cover your gram positive. So this could be a case of osteomyelitis. So he was started on meropenem. Now he continued to be febrile. On examination, there were signs of inflammation present over the IV port as well. On day 2, the blood culture flagged positive and it grew MRSA. Sorry. The next day, even the joint aspirate grew the MRSA. So this is the report you have in hand. The vancomycin, you can see in the report, the vancomycin MIC is 1. Then vancomycin MIC was repeated by E-strip that showed has 2. So now, will you continue the same treatment? So the patient was initially on meropenem. Based on the MRSA report, they have started on vancomycin, and now they are getting this report as vancomycin MIC is 2. So up to 2 is still sensitive. So vancomycin is still sensitive. So even in this situation where the vancomycin MIC is 2, will you still continue vancomycin, or you will you have to change the treatment? So this is a very important aspect. So whenever you're reporting or whenever you're getting vancomycin sensitivity, it is better that you get it by your MIC value. And again, if the patient is not responding, again you have to repeat the cultures and look at the MIC value of vancomycin, because vancomycin is notorious for something called MIC creep. So the organisms usually will have organisms having vancomycin MIC between 1 to 2, though will be reported as susceptible, will have reduced susceptibility to vancomycin. This is called the MIC creep. So you have to either monitor the MIC, and it is recommended if the vancomycin MIC is more than 1 or more than 1.5, you use an alternative agent. And also whenever there is reduced susceptibility to vancomycin, there is reduced susceptibility to teicoplanin as well. And that's what MIC should be the ideal testing method and not diffusion. And what are the risk factors for these? It includes age more than 50 years, prior administration of vancomycin for more than 48 hours, CLD, presence of a central line or history of MRSA bacteremia, or patients who are on long-term vancomycin or teicoplanin therapy. So what is this brings to the last topic of discussion, the management of persistent MRSA bacteremia or the vancomycin treatment failure cases. So first is you have to, again, as I mentioned, local source control is very important. Foci, find the foci and remove the foci. Or if there is still no response, you can give high dose daptomycin plus gentamicin, or basically the combination of daptomycin with beta-lactam or daptomycin with gentamicin. Again, the combination therapy is one more discussion per se. So I'm just trying to keep it brief here. If and now the patient, if there is reduced susceptibility to both vancomycin and daptomycin, what you will do in that situation? You can try quinprestone, dalfaprostone, linezolid, co-trimoxazole, or telvancin. So next, difficult to treat MRSA infection. So the suggested combination, you can use high dose daptomycin plus rifampicin. Especially in situations where there is high inoculum, especially in case of osteomyelitis or very deep-seated infection, you can try this combination of high dose daptomycin with rifampicin. Vancomycin plus beta-lactam can be used, because beta-lactam like ceftaroline can be used. So the ceftaroline will enhance the binding of vancomycin, and if you use nafcillin, it will reduce the cell wall thickness, so this vancomycin can adequately act. Daptomycin plus beta-lactam like ceftaroline can be used, as I mentioned before. So this reduces the cell surface charge and enhances this daptomycin binding, and hence this combination can be used. Fosfomycin and imipenem in a refractory case where there is no other response, and you can go, this is one of the rare combination which can be used, because fosfomycin will downregulate the PBP2, so that this imipenem can become effective. Again, these are the rare ones. So the evaluation of combination therapy Again, it is a part of SNAP trial of the Staphylococcus, which is ongoing. And this is one paper which they have looked at the combination therapy in methicillin-resistant bacteremia, whether it will work and which combination and for which patient. So this is a very nice flow chart they have made in this case. So in this, patients having sepsis and the patient is growing GPC, then if there is, they are advised to monitor the IL-10 level. And if the source is skin and soft tissue infection, you can, or pneumonia as a source, monotherapy can be used. If there is no obvious source or if the patient is a high risk patient, then they recommend combination therapy. That is the combination which I mentioned already before, Adaptomycin plus ceftaroline or Adaptomycin plus anti-staphylococcal beta-lactam. Again, this is a topic for discussion for like another session. So I will be considering for later. So summarizing, so whenever a patient is having suspected or proven Staph aureus bacteremia, you will have to give a combination of a glycopeptide with a beta-lactam, and then once it is confirmed, you have to you should ensure you are repeating every 48 to 72 hours cultures, apart from doing the screening for metastatic foci, including your TTE and then TEE. So if it is MSSA, you will stop vancomycin. If it is MRSA, you will stop the beta-lactam drug. And then depending upon the type of bacteremia and the source, adequate source control, you will be giving the total duration. For uncomplicated bacteremia, you will be giving overall 2 weeks, whereas in case of complicated bacteremia for up to 4 weeks. So again, this is one of the summary. This one summarizing the various drugs and its effect in the different types of infections. So vancomycin, as we can see, it has a good effect on most of the places, except for pneumonia is plus or minus, because linezolid has a better drug according to the SAB trial. Teicoplanin, as I mentioned, it has very bad CNS penetration, so it is not recommended. Clindamycin, bacteriostatic, again, it's not recommended in cases of your infective endocarditis, and as I mentioned, in CNS as well. Other drugs like linezolid, it's plus or minus bacteremia, as I have shown, it is non-inferior to vancomycin, but again, because it's a bacteriostatic agent, it is very tough call to take a call on whether it can be used or not. In cases of your pneumonia and skin and soft tissue infection, linezolid is a preferred drug of choice. Adaptomycin is a very good drug in cases of your bacteremia and osteomyelitis, and in cases of infective endocarditis. So that's it. Thank you. So I'll be happy to take the queries now.